Welcome back, those who are auditing this algorithm for the pharmacotherapy of OCD. And this is video 2 of that algorithm, and it's about comorbidities and other circumstances that could lead to variations in the treatment algorithm. Now, I haven't presented the algorithm in detail as yet, but as you proceed to the second step of the algorithm after diagnosing OCD, you do also need to consider what comorbidities that might be present could affect the choices in the algorithm and could lead to deviations from the standard recommendations for the case that has no comorbidities. So screen for and treat medical comorbidities to start with. There may be some that could significantly impact the capacity to respond to treatment. A few that I'm going to discuss in more detail, though, start with women of childbearing potential, which isn't a comorbidity, it's really like a circumstance, and pregnant women are included in this category. So they have some special considerations, because late exposure to SSRIs may increase risks of neonatal complications, including premature delivery, decreased body weight of the infants, and persistent pulmonary hypertension. So this is an association that has been found with late prescription of SSRIs and these outcomes. But that doesn't mean it's a cause and effect relationship. There's confounding by indication. In other words, the reason that people were prescribed an antidepressant may be the reason why they're at higher risk for these outcomes, and not the use of the antidepressant itself. Now, in these various observational studies that are done in pregnant women, they usually try to have a control group that they compare to the pregnant women getting the medication to see if there are differences in their outcomes versus the ones getting the SSRIs. We have to go by these observational studies as the best that we have, and they are confounded by indication. There were no differences in neonatal outcomes, including birth weight, gestational age, or need for a neonatal ICU admission, though, in women treated with pharmacotherapy. So at least some of the major concerns associated with medication in pregnancy did not seem to occur with SSRIs. We would, though, avoid paroxetine. It has a D rating in the old rating system that the FDA used for pregnancy risk. D used to mean that there are some known risks, significant risks of fetal harm. And with paroxetine, the fetal harm was atrial septal cardiac defects being found at higher incidence than expected. So we think you should not use paroxetine in pregnancy, or if a woman is on it, happens to be on it, and gets pregnant, we would consider switching off it to something that might be safer. Overall, though, the risk to the newborn of untreated OCD and having the pregnant woman go through pregnancy while exhibiting significant OCD symptoms may outweigh the risks of medication treatment of that OCD. That's a tough decision to make. It certainly should be made in collaboration with the patient and significant others of the patient, as well as the prescriber. A psychiatric comorbidity that I want you to identify immediately before starting treatment is bipolar disorder, a disorder which, by the way, is frequently misdiagnosed and missed, especially when people are having depressions. There's a failure to recognize that there may also be hypomanias going on, and these are really bipolar depressions. So carefully diagnose whether there's bipolar disorder before commencing treatment for OCD with an antidepressant, because we don't recommend antidepressants if you have bipolar disorder. They may shift euthymic patients with bipolar disorder toward more manic episodes, especially in the second 6 months of treatment, even if they're also on a mood stabilizer. And also, there are recurring depressions in people with bipolar. SSRIs may cause more cycling back to depression. So we prefer not to use them, even though they're prominent in the algorithm. So what do we have for bipolar patients with OCD? Well, what we have is psychosocial treatments, psychotherapy. CBT is well established as effective. I think that would be first line. And we would not use antidepressants. Now, as far as what medication you could use, we have one randomized controlled trial with Memantine, 20 milligrams a day, added to mood stabilizers as an adjunctive agent to the OCD in treating OCD symptoms in manic patients. They had a response rate of 79% in the Memantine group and 37% in the placebo group. There were few side effects, but it was a small study, only 38 patients. So that's the evidence base that we have for pharmacotherapy of OCD in people with bipolar disorder. So to conclude this second video, the key points that were made. Number one, as you prepare to choose treatment for your OCD patient, consider various medical and psychiatric comorbidities. Regarding women who could become pregnant, the risks are mild on fetal defects except for paroxetine, which has significant risks of fetal harm. Generally, the benefits are worth the risks of SSRI treatment, but it's a collaborative decision with the prescriber, the patient, and family. And regarding bipolar disorder as a comorbidity, we do not recommend using any antidepressants. Instead, we recommend cognitive behavioral psychotherapy.